Welcome and thank you for joining us this afternoon. My name is Kathy Chern and I'm a Consumer Health Librarian at East Brunswick Public Library. This Lunch and Learn series is sponsored by Princeton Radiation Oncology, Regional Cancer Care Associates Central Jersey Division, St. Peter's Healthcare System, and the Libraries Just for the Health of It initiative to promote community health and wellness. Today's speakers are Dr. Hiral Patel Fontanilla, Radiation Oncologist at Princeton Radiation Oncology, Dr. Lisa Hopkins, breast surgeon at St. Peter's Breast Center, and Dr. Ellen Ronnen, medical oncologist at Regional Cancer Care Associates, Central Jersey. Before I turn things over to today's speakers, I would like to ask you to please mute your microphone and turn off your video. If you have any questions, please type them into the chat box. Our presenters will answer questions at the end of the talk. Please be aware that this talk is being recorded. And without further ado, I shall turn things over to the doctors.
Hi, it's Ellen Ronnen. I'm going to start us off. And thank you for joining us today in this, I was going to say in the morning, but it's actually now the afternoon. And so what we wanted to do in this series of lectures, of which we're the first one, is we wanted to talk about individual types of cancer and how the care of them might be slightly altered or changed because of the coronavirus pandemic. And so I'm going to start us off, and then joining me will be Dr. Hopkins and then Dr. Fontanilla. So just to give you a little bit of a breast cancer overview, although we will have a slant towards how things are changed now, breast cancer is very common, as you all know, and there are 280,000 cases of breast cancer in this country per year. That's invasive. In situ disease is another almost 50,000. So it's a disease that we see a lot, and it's either lobular or ductal. Ductal is more common. For our patients with breast cancer, they can receive surgery, radiation, and systemic therapy. We see the body as a system. So any therapy that's given to your whole system, like chemo or an anti-hormonal therapy, is considered systemic therapy. And they're all considered in breast cancer management. You don't necessarily get all of them depending on what your specific situation is. And I wanted to take a moment to talk about the estrogen and the progesterone and the HER2 receptors, because they're very central to determining the care of breast cancer patient. And so you can have one of the receptors, two of the receptors, three of the receptors, or none of the receptors. When you have none of the receptors, it's considered triple negative breast cancer, which is considered a high-risk subset. And I'll talk about it more when we determine what we should do for an individual patient and how we divide patients in terms of whose care has to be expedited regardless of what might be going on in the world around us. Can you advance? So these questions are questions that all three of us have received since this pandemic began. And the pandemic is changing in that thankfully in New Jersey, numbers are improving, but these questions have been asked, well, the questions related to medical oncology have all been asked to me in the last few weeks. So I do think that they're relevant. And some of the questions we've received from our patients when we've been doing telemedicine visits with them or live visits are, can I delay my mammogram? I have a mass growing in my breast. Should I get a surgical appointment? And actually, I've also spoken to some of the primary doctors in the community, and they also have been, they've gotten calls like that because some of their offices are closed. And so they were questioning, are surgeons' offices open? I have an infection in my breast. Do I have to be seen? I was just diagnosed with breast cancer. My surgeon said it might be best to do non-surgical treatment first. What do I do? I just had my breast surgery. The surgeon said I need radiation. Can it wait? I'm already on radiation. Can I continue during this COVID? I'm on chemotherapy, but do I have to continue during the pandemic? So these are some of the questions that we're going to endeavor to try and answer today. And I was going to hand it over to Dr. Hopkins to begin discussing the surgical management and how she approaches patients with masses in their breast or who would be getting imaging. And then I'll talk to you more about the systemic therapy.
Ellen, then before you close your slides out, can you go to the slide about the, yeah, that one, perfect.
Sure.
Hi,
You
thanks
want
everybody for, can
Do
you
you
hear
want
me?
me to explain the priority A, B, and C really fast?
Sure, yeah, you can go ahead and do that.
So this table was created right when the pandemic began by two kind of governing bodies of our American Society of Clinical Oncology and the American Society of Breast Surgeons. They made recommendations on who you should be bringing into the office, who you should be doing X, Y, or Z for, and they prioritized them into A, B, and C. So A are the patients who should not be delayed, and B are the patients who you could delay up to 6 to 8 weeks, and C are patients who, depending on what the X, Y, or Z is, you could delay longer.
So, hi, thanks everybody for tuning in. So I'm a breast surgeon at St. Peter's. Our office is open. We are still seeing new patients. And essentially the patients that are priority A are the patients that we're seeing in the office right now. So patients who do have breast infections, because obviously those need to be taken care of. And anyone who's been newly diagnosed with breast cancer, we are not converting those to telemedicine. We are still doing physical exams, and we're taking every possible precaution that we can to keep everybody safe and their exposure limited while they're in the office. Can I do your next slide, Ellen? And then I'm going to switch back over to mine. I'm just going to back up a little bit because we have been getting questions as far as delaying mammograms. And this has certainly been evolving over the last few weeks. About 1 month ago, we really were not doing any kind of routine screening. So if someone is having no issues whatsoever and they know that they were due for their mammogram in, well, now it's May, and would it be safe to delay that until June or July? And that would be 100% safe to do. The imaging facilities are slowly making plans to reopen to get the screening and the routine imaging back on board again. But for now, anyone who absolutely has a new lump in their breast or who did have an abnormal screening and needed some additional imaging, diagnostic imaging, or if they've had some other kind of symptom, we are still doing diagnostic imaging and again, maintaining social distancing and hand washing and cleaning to make sure that that's being done in the safest possible way. Let me go back here 1 second. I'm going to dive a little bit more into the surgery recommendations. So hold on, my technology. Okay, I'm going to share this now. Okay, can everybody see that?
I can see it.
Can you see that? Okay, so I just want to go over some of the recommendations for breast surgery. So in general, when women are diagnosed with breast cancer, in most situations, the first step is going to be surgery. We generally have the option of a lumpectomy versus a mastectomy. So a lumpectomy removing just a portion of the breast that has the tumor, or a mastectomy removing the entire breast. I would say probably about 80% of the time, on average, 75 to 80%, we are able to do lumpectomies. These can usually be done as an outpatient procedure with a low risk of complications because we're essentially doing surgery on soft tissue as opposed to the GI tract and things that the risk of complications, bleeding, infections are higher, not so much with breast surgery. And the fact that we can do this in an outpatient setting so we can avoid being in the hospital setting where obviously the patients are sicker. So Dr. Ronnen just mentioned the 3 priorities, so I won't go back over that again. Essentially, the priority C's are going to be the patients that we really don't need to do anything with right now surgically, where we feel that the risks of bringing someone into a medical setting would be far worse than the risk of letting them wait a little bit longer. There really are just a few situations that are priority A. Most breast cancers at this point are kind of fitting into this priority B, which means things are stable. There's nothing emergent about their condition, And certainly a delay of a few weeks is not going to change their outcome, but it is something that we want to take care of in a timely fashion. So for priority A, we're basically looking at very significant breast infections or abscesses that need to be drained, and anyone who is bleeding and unstable. So this is not going to be the vast majority of breast cancers, but these are going to be the patients where, heaven forbid, you have some kind of bleeding or a bad infection or anything in the breast. This is something that we can take care of safely for you now, and surgery should not be delayed. Most breast cancers, as I said, are going to be priority B. As long as the resources are available, we should still plan to do surgery and do that in a reasonable time period. We have been, we obviously had our share of the pandemic here in New Jersey. In central Jersey, it does look like we have begun to, actually more than begun, but we have plateaued. So the resources are certainly available. And, we're looking at any patient who, if they needed chemotherapy first and are ready to have surgery, we're usually going to want to do that in a certain time period. If that's happening to fall right about now, we can safely do that. Newly diagnosed breast cancers, we have the ability to take care of them now surgically. That includes the triple negative breast cancers, the HER2 positive, or women who have larger tumors or node positive tumors. And we'll kind of, once we get into Dr. Ronnen's portion, we can kind of go back and forth as far as what's sort of the best way to treat these particular patients. It is certainly something that we do as part of a multidisciplinary team, and every patient is individualized. So we're going to do what we feel is going to be the best and safest for every single person. If there are women who have had a biopsy that came back benign, but we think it's more likely to be something malignant, what we call discordant, they should likely have surgery sooner rather than later, and anyone who has a local recurrence of their tumors. Priority C actually had a pretty wide list when these recommendations first came out. So DCIS, which is like a precancerous type condition, even small breast cancers, the initial recommendations were saying that these could be delayed, with the caveat that is, it's more if the resources would not allow us to take care of those now. Again, as things seem to be evolving, and hopefully will be continuing to evolve, there should not be a large delay in those as well. And again, some of these other things I mentioned, like prophylactic surgery and excision of benign lesions, certainly we don't think that they're going to be risky enough that we would have to do those now. But some of these other higher risk lesions or even small breast cancers we are taking care of, in a timely way. And then just kind of overall, as far as keeping everybody safe, again, as I mentioned, most of these surgeries can be done in the outpatient setting where we're going to be limiting your exposure. Our staff has been rotating as well. So there's no one person that's, getting over and over exposed. There's been questions about whether anyone can even come into the surgery center with patients, and we are allowing one support person. So it's enough that no one's going to be sitting in surgery, without someone there supporting them. But we also don't have a big crowd in the waiting room. So we've been able to maintain social distancing in all the waiting areas, in the pre-op, and in the recovery room. We've been doing universal masking, so the patients, the support person, and all the staff have been masked, and regular cleaning and hand washing, just to kind of overall, keep the burden of any disease down. I think that's all I had as far as slides for the surgery part. So I will turn it back over to Dr. Ronnen.
Kathy, are you going to put my slides back up because my share screen wasn't working?
Okay, can you see it now?
Yeah, so I think the slide, so is this the one right? No, you can go back one and can you go back one more? So in terms of what we're doing on the medical oncology, no, you can go to the one after this one. Perfect. So in terms of what we're doing on the medical oncology side, and our medical oncology patients, there's a big range. We have our newly diagnosed patients who we met shortly before the pandemic began. We're meeting new patients even during the pandemic. And then we have our long-term follow-up patients. And by the way, I can see in the chat that many patients are asking long-term follow-ups in terms of what's their risk, and I'll try to touch upon that. So I wanted to focus on priority C, that column. So we, as a practice, we've converted our routine follow-up visits, and we're trying to do all of our follow-up visits for the moment telemedicine, so that we can keep safe as safe as possible our chemotherapy patients and have very limited traffic in the office. And then even within the chemotherapy suite, we're trying to keep patients very separated with no visitors. Everyone is masked. But the patients that I'm seeing every day doing telemedicine a lot of them are established patients, and telemedicine is reasonable for those patients. The only issue is that obviously they can't get an exam, and I think you do lose something with a personal touch. And so we are hoping, as the pandemic hopefully winds down in New Jersey, to bring all of those patients back to the office. But for the moment, they can all be seen via telemedicine. Survivorship visits are visits that are now mandated by many of the societies, the oncology societies. And what they are is after you've completed curative therapy for your type of cancer. So breast cancer is one of the most common. You're supposed to have a visit, and usually they're with a nurse practitioner or a PA, and otherwise known as an APP. And what they're supposed to give you is a map of what you should do going forward and where you've been. So those visits will go over the treatment you might have received, the schedule for when you're supposed to see your team of doctors, be it surgeons, radiation oncologists, medical oncologists, how often, you might need some of mammograms and all of that. And that visit can also be via telemedicine, because it's really sharing information, but it's not necessarily a physical exam. I do think those visits are important as an aside, because part of that visit is ultimately you would get that paper where it says if you've received chemotherapy, the names of the drugs and the doses. If you're on hormonal therapy, it says the name of the drug. And I've talked to some of my patients from years ago, and before we started doing this, they have no memory of the treatment they received. And then obviously the well breast visits are, patients who are well, and obviously they can be done via telemedicine. So moving on, I think the next slide was the mammogram slide. So from the medical oncology perspective, we're not seeing the new breast tumors necessarily. We're seeing patients who I've treated or, just finished treatment, and they're asking, many of them don't want to go in to get their routine imaging. Now, I think this is changing, as Dr. Hopkins said, and I think you'll hear from Dr. Fontanilla. And I think the imaging centers are aware that this is a moving target, so to speak, and they're trying to reinstate a lot of this, because if this is our new norm for a prolonged period of time, we have to find a way to safely get people the imaging they need. But I want to reassure my patients, and I do when I speak to them, that if, they were diagnosed 3 years ago, they're on annual mammograms and it was due in April, that it's fine to do in June or July if they don't feel comfortable coming in June. So I just wanted to go over that one point, that most of my patients have said to me they don't want to come in right now and they want to delay the mammogram a few months. And as Dr. Hopkins said, that's entirely reasonable for a routine follow-up patient. So then moving on with the next slide, we're going to talk more about, so there's chemotherapy that I wanted to touch upon, and also endocrine therapy. Endocrine therapy is the title for all therapy that in some way would decrease the estrogen that a tumor sees, either like tamoxifen, which is a selective estrogen receptor modulator, which is a complicated bunch of words together, or a drug that actually decreases the production of estrogen, like Arimidex. So I'm going to talk first a little bit about the chemotherapy, and then I'll talk more about the endocrine therapy. Regarding the chemotherapy, what I'm saying here mirrors in many respects what Dr. Hopkins said, and it's all about risk groups of patients with breast cancer. We do think the high-risk patients are the triple-negative patients and the HER2 patients. We are trying very hard, and the organization, the groups that have brought out these guidelines have also said, do not delay these patients unless you really have to. So the triple-negative patients and the HER2 patients, we have begun their chemotherapy during the pandemic, keeping them as safe as able, and as I said, making modifications in the office to decrease their coming into contact with anyone. In the same vein, if you are a high-risk patient and you are almost done with your chemotherapy for, say, your triple-negative tumor, but then the pandemic began, we would strongly recommend that you complete the therapy, the chemotherapy, if you're a high-risk patient. The other group that has been recommended that you try not to delay chemotherapy too much is a subset of advanced cancer patients. So in an advanced cancer patient, some patients, and this is very uncommon in breast cancer, which is much more often caught early. If a patient presented with, very advanced disease in many different locations in their body, it might be recommended that they start chemotherapy without delay to prevent any organ damage. So if they have a large lymph node that is potentially going to block their kidney, that would be someone that you would say, let's get you on chemotherapy for a short time, shrink the lymph node, preserve your organ function, then we can talk about switching. So those patients are the group that generally chemotherapy is not delayed. So who can you delay chemotherapy in? And I think this will also change as the pandemic slowly resolves, but this is where you get more into the patients who are ER and PR positive. So ER and PR positive patients have two options potentially. They have the option of getting endocrine therapy, and then depending on their level of perceived risk, you might need to add chemotherapy to the endocrine therapy. And there are tests available to estimate their perceived risk and whether or not you need to add chemotherapy to their endocrine therapy. And those tests, Oncotype DX, have been around for far longer than the pandemic. Oncotype DX, I believe, began testing patients around 2003, I believe. So we should be using this, but it's even more strongly recommended that you consider that test for your ER and PR positive patients. It's a test done on the breast cancer tissue. The reason why is because if you weren't going to send it and you were just going to assume you needed chemotherapy, if the patient came back low risk, you would feel better about not doing chemotherapy at all. Now, if their risk came back intermediate or high, you would want to give chemotherapy, and chemotherapy is usually given before endocrine therapy because it's shorter, and then endocrine therapy would go on for years. However, in some patients, depending on the patient's individual risk, you might consider changing the order of those. I actually have not done that, and when I've had to start chemotherapy during the pandemic because the patient had higher risk with an ER/PR positive tumor, we've been able to do it safely. But the guidelines do say you can consider changing the order of your modalities, of your specific treatments. And the reason why is because in an ER/PR positive patient, you have both of those options because they will also respond to the endocrine therapy. And then the other group, so that's kind of how you would manage those patients in the hopes that you can avoid chemotherapy altogether if they were low risk. And again, if they were intermediate or high risk, you could consider altering the order, although that's not done a lot. Many patients with HER2 positive tumors, as I discussed earlier, are high risk. Well, they're all considered high risk, and they will always be recommended to start chemotherapy immediately. But the chemotherapy part of their HER2-based regimen ends, and then the HER2 drugs, as many of you know, will go on for up to a year. And it is recommended that you try to complete the HER2-based drugs. However, there's a small amount of data, and this is generally being brought up now because of the pandemic, that if a patient has received over 6 months of their prolonged year of the Herceptin HER2-based therapies, if they want to stop early, they could. personally, Herceptin does not increase your immunosuppression, and so I would favor giving it, but some of my patients have expressed to me just in the last 2 weeks that they don't want to come into the office, that they're just too anxious about it. So I wanted to bring up that possibility, but again, the recommendation is you at least get yourself 6 months out. And then the other group where you might try to delay chemotherapy is in an advanced cancer setting where a patient has had many therapies, their disease is stable, and you would say if they're very concerned or if the pandemic starts to increase in numbers again, that you might consider giving them a chemotherapy holiday. This was talked a lot about right when it began in March. A lot of the major centers in the area were saying to give patients 4 to 8 weeks of a chemotherapy holiday. I think as our numbers improve, we're going to be looking less at giving patients holidays, because if everything is better outside, let's get them on therapy to control their advanced disease, especially if we would expect a second wave. So moving on to endocrine therapy, which I think is the next slide. So my patients who are on endocrine therapy, which as I said, can be tamoxifen, Arimidex, Aromasin, Femara, my patients on those drugs have also asked if taking those drugs will put them at increased risk if they go outside, and should they stop it. So those drugs do not immunosuppress you, and you can take them. If you've been taking them, you can continue taking them. There's no data that it's going to increase your risk of contracting coronavirus or make you higher risk of side effects. If you're a newly diagnosed patient and the doctor is recommending to start these drugs, it's also safe to start them during this time. The risk isn't higher because you're just starting it versus you've been on it for a year or two. There's not an immunosuppressive component of these drugs. Some younger women who are still premenopausal are recommended for their endocrine therapy to get ovarian suppression and an aromatase inhibitor, also known as an AI. And if that's the recommendation for your endocrine therapy, it is completely reasonable to get both of those parts at or during the pandemic and not to delay it. The AI will not work without ovarian suppression in that population, and ovarian suppression will not immunosuppress you. So again, we want you to take what's safe, and this is entirely safe and should not be delayed. So there are newer drugs that this is talking about the advanced cancer patients, but there are newer drugs that we've been using in the last 5 to 10 years that are not chemotherapy drugs, and they're added to the standard endocrine therapy. So if I typically was going to give a woman Arimidex, I might now give her Arimidex and Ibrance. And if you're just starting a patient with advanced cancer on these drugs do have the side effect, not just when you start them, but all along, of dropping the white count. And so to get a sense of how the patient would do, you are supposed to bring them in frequently early on to check their white count. It is recommended that if you're just starting them, you can start the aromatase inhibitor, and these additional drugs can be delayed, 4 weeks, 6 weeks, 8 weeks, just so the patient is not concerned about coming into the office on a weekly basis for counts. And then as things are opening up, specifically for us in New Jersey, and where all of our patients are returning to the office, the patient won't be concerned about coming in for the weekly counts. And they also won't be concerned that their lower counts might put them at increased risk for an infection. So I wanted to highlight that subgroup. And so the next slide is talking about related tests. So as many of you who are listening know, if you're on certain drugs, including the HER2-based drugs, you're supposed to get echocardiograms while you're getting them. And the recommendation for tests like this is that if your echocardiogram was done and you've been getting it every 3 months and they're stable, that you can actually delay your echocardiogram if you want until the pandemic is improving. I think we're actually getting close to that, but most of my patients, including patients I spoke to yesterday, asked me if they could delay their echocardiogram to June, and that's reasonable. Their last one 3 months ago was fine. Making it a month or two later is fine. And in the metastatic setting, patients who are getting CAT scans, if it was previously stable, I also spoke to patients this week. So patients are really having these questions, which is why I brought this up, because some of you might have the same ones. And they asked me, can they also delay? I think June is the time people feel like things are changing for the better. So one woman asked me if she could do her CT scan in early June, and that's fine. Her last one was stable. We don't think we're putting her at increased risk by waiting. The last thing I wanted to mention is patients are often very concerned about maintaining the function of their ports, and they've been told that need to be flushed every 6 weeks. So I wanted to just quickly mention that it is completely safe for port flushes to be changed to every 12 weeks, which will bring patients into the office less frequently, which patients like, but it will not affect the integrity of your port. And then my next slide is just talking about what else can you do during this pandemic that will keep you safe. And I think this has been a very stressful time for everyone. And I'm sure you've all heard on the news that there is really a mental health component to this that we shouldn't try to diminish. So from the physical health perspective, we all know to really practice social distancing, to wash your hands, to keep your hands off your face. There have been many articles, including one in the Wall Street Journal that we actually have on the RCCA website, on how to be safe in the grocery store. And it's common sense, but it bears repeating, and you can read it, but it basically says, you know, when you're in the grocery store, look with your eyes, not with your hands when you're trying to decide what to take. Try to avoid people, know what you need to get before you enter the store. But from the mental health perspective, and my patients also have asked a lot about this, it's very important to keep yourself connected with friends and family electronically. It's not the same, and the Zoom family meetings every Wednesday or whatever night you all choose are not the same, but it is important to keep talking to people and to not become isolated. Similarly, some of my patients have expressed anxiety because they're reading so much about it, and it's really all that they are doing because they're home and the computer or the phone is there. So really try to avoid information overload. And whatever you are reading, try to make sure it's a reputable source. Lastly, with my patients who are telling me they can't sleep at night, try not to read the news before you're going to bed. This is generally a good tip for year-round, regardless of what pandemic we have. But it's especially bad because what you're reading can be very upsetting. And so when I say take social media breaks, I mean two things. So don't read it the whole day. Maybe say, I'm gonna check what's going on 3 times a day, but have your last time be not too late in the day. Do something relaxing before bed, because I do want all of our patients to sleep. Rest is important, and it helps us in preventing infection. And then lastly, specifically, get mental health support if you think you need it. There are virtual options. Cancer Support Community is a group we work with a lot that has offered free virtual sessions, but we can also find more resources if you need, so never hesitate to ask. I want to hand it over to Dr. Fontanilla now, who's going to talk about radiation and how its care might be affected by the pandemic.
All right. Thank you, guys. Let's see here. Here we go. So I'm going to touch on just the radiation portion of this, but I think that Dr. Ronnen and Dr. Hopkins have mentioned a lot of good information and just an overview on a basic approach to things. I'm going to skip that part of it. So in general, radiation treatment is local treatment, like surgery, in that it only affects the part of the body that we treat. And the radiation treatments generally are daily treatments for a few days to few weeks, up to 6 to 7 weeks. Generally speaking, radiation treatment does not impact the immune system, so it's not immunosuppressive the way that some chemotherapies might be. And the side effects typically tend to be tiredness and irritation of the local area. In terms of treatment for breast cancer, most commonly, radiation is used to treat the breast, chest wall, lymph nodes in the area. It's usually done after surgery, but occasionally can be done before or instead of surgery if surgery is not feasible. Also, occasionally, if breast cancer is spread to other areas, then radiation can be used to treat those areas. And how we approach radiation for each of these situations is a little different, and how we think about the timing and urgency of things as well. Typically, radiation starts 1 to 3 months after surgery. if it's used in that situation of radiation done after surgery in sort of a preventative setting. Even outside of the pandemic, waiting 1 to 3 months after surgery is the normal timeline, or waiting about a month after the last chemo. Most research studies over the last 50 plus years that have included radiation for breast cancer have used that time frame up to a 16-week time period after surgery, and that's considered a safe timeline even outside of the pandemic. For some situations, for emergencies like if somebody has a tumor that's pressing on their spinal cord, or a tumor that's causing significant bleeding, things like that, there were true emergencies, we can start the treatment within hours to days, or other situations where somebody's having pain, swelling in a certain area, treatment can be started and is often started within days. So specifically to the pandemic itself, with regard to the radiation, generally because it doesn't impact the immune system in the same way, the real risk is from exposure to other people, especially because of daily treatment, exposure to other patients, staff, to the facility, exposure during travel to the treatments, especially if somebody needed to take public transportation to get to their treatments. There's possible concern of limited resources, and this was much more so when at the very beginning of the pandemic, when there was this real sense of worry that there just wouldn't be enough medical personnel, and that we wanted to really prioritize who needed radiation. Initially, and to some degree even now, there's shortage of personal protective equipment or masks. And so especially in the early part of March, there weren't enough masks, there weren't enough guidelines of everybody being able to use the best protective equipment. There was concern, and may still be, of having enough resources in terms of cleaning supplies, hand sanitizer, things like that, ways that we can make radiation treatment for somebody as safe as possible. And if we can't, we really need to be able to prioritize the way that Dr. Hopkins and Dr. Ronnen mentioned, of where it is the most urgent and what can safely be delayed. Fortunately, in terms of radiation, we're not worried about high-risk procedures like intubations. We're not doing things where there's going to be an additional risk of aerosolized procedure where we worry about spread of the coronavirus in our department. We're not worried about causing people to be immunocompromised. And for most of our departments where we're separated, whether within the hospital or in a separate center, there is not a significant risk of cross-contamination with patients that are admitted to the hospital that have diagnosed COVID-19. Our staff is generally not in the hospital, and they're not taking care of other patients as well. So the risk of cross-contamination is fortunately also a little less with radiation. To go back to that, the guidelines that were mentioned already, in terms of radiation, the things that are really priority are painful bleeding areas, patients that are under treatment. A radiation treatment break can be really troublesome in that it lessens the effectiveness of radiation. So it's very important that for somebody who started radiation prior to all of this, that they continue it unless there's really some major reason to not do that. There are times where I would consider interrupting radiation treatment is if somebody was diagnosed with COVID-19 and it was otherwise safe. I think taking a few day break to get tested, maybe a longer break to complete their recovery from COVID-19. I think those are situations where a treatment break in radiation is certainly reasonable, but otherwise we try and limit that. The second category of being safe to wait 6 to 8 weeks is patients that are getting postoperative radiation, patients who who are at higher risk, the patients who are already fairly far out from surgery, 3 to 6 months from surgery or chemotherapy, that are intermediate risk. Any patients that have estrogen positive tumors, as Dr. Ronnen mentioned, starting them on anti-estrogen treatment can also buy us some more time. And I think, again, for the people in that second category, now that we're far enough out into this pandemic, and hopefully it's starting to wind down, these are people who I think are fairly safe in terms of being able to do radiation, but it's also safe to hold off for a little bit longer if we needed to. And then there's another category of patients who, according to the guidelines, you can wait to the end, and which we don't really know what will be considered the end of this pandemic, but I think we're definitely getting to a much safer time where the risk of exposure is getting less. Patients who have an earlier stage, hormone-sensitive cancers, smaller tumors, DCIS, things like that. And I think these guidelines really established a template for what is safe to delay, and helped us make sure that as we get through this time period, that we're prioritizing if we need to. But I think now that there have been reasonable changes to the practice of radiation treatments, I think that treatments can be safely done in the usual timeframes. And again, for every person, talking to your oncology team is the best way to go. What we have been doing in our practice, and I imagine many other people are doing, is to try and lower that exposure by limiting the number of people that our patients come in contact with. We certainly, whenever it's possible, defer treatment for patients who have been diagnosed, so that it lessens the risk to every other patient in our treatment area and our staff. Screening of all staff and patients, and testing for anybody who is at high risk because of symptoms, fever. Fortunately, now there's tests that will come back within a day or two to give us more of a sense of safety. Universal masking, ideally, the staff that is coming in contact with many patients every day, ideally for them to have an N95 mask because their exposure is just a lot more. And then for everybody else to have surgical masks, for patients to have cloth masks or surgical masks, but to have that extra layer of protection, making sure that there's limited or no patients in the waiting area. We have patients wait either in their cars or by themselves, not having a support person with them, unfortunately can be very tough. But for our patients where they're coming in for daily treatments, and there's there isn't that same one day process, I think not having the support people helps us keep exposure down, making sure that everyone is cleaning their hands, cleaning surfaces often, whenever possible, other than the staff that's directly helping set up for radiation, keeping a safe distance during the time that they're in our department. We've been limiting the number of people that are coming in contact with each other, that because our patients are coming every single day, if they were meeting a new staff member every single day, I think that risk would be higher. And then I think in general, we want to always make sure that people are limiting the any exposure during the travel, certainly taking if somebody had to take public transportation to get to treatment, that would be something that would be a huge deterrent for me. I would definitely not want people to be doing that as long as they're in those categories where it's safe to wait. I think, fortunately, the big peak of cases and risk is getting better, but I think in some form we will continue to need to be really safe with regard to COVID-19 and other infectious diseases. But I also want to make sure that everyone is still taking care of their other medical issues as well. And if your team is recommending continuing certain treatment or suggesting that a CAT scan or a PET scan or an echo, it really is something that needs to be done sooner, that there are ways to do it safely. And I want to make sure that anxiety is not stopping any of us from taking care of the cancer portion of this as well. Active treatment, follow-ups in a timely way, screening and preventative care. And as Dr. Ronnen mentioned, waiting till June, July, for many patients, it is perfectly safe. But I also want to make sure that if your team is recommending that you get something done, there are ways that you should advocate for yourself to have a safe environment to get it done. Wear a mask yourself, ask anybody that's coming in contact with you for them to wear a mask, make sure that they're washing hands, make sure that when you go to a facility that they have ways that you can clean the surfaces that you're going to be around, that they have enough things set up there that you can keep distance from staff and other patients. And if you don't see that, that you ask for it, because it is something that you have in your control to be in a safe place. And I think the one of the questions that came up earlier about patients or somebody who's completed their treatment 5 to 10 years ago, at least my understanding of all of this is that I don't feel that they would continue to be immunocompromised. I think there is some feeling that anybody that has had treatment maybe has a slightly different immune system than they did before, but I don't think it changes your immune system in a way where I would want you to do anything different than I would want any other high-risk person, anybody older than 60, any other medical conditions. And so I I'll stop sharing and we can kind of open it up to everyone.
So, can you hear me?
Yeah.
I just wanted to comment on the question that I already saw, and then we'll ask more. And I agree with Dr. Fontanilla. From the medical oncology standpoint, someone who is 5 years out, I don't think there's any data that you're at increased risk of getting COVID or having more serious consequences from it, assuming that you've recovered from the chemotherapy and you don't have any long-lasting toxicity and any new medical problems that occurred. And what I mean by that is that you could argue that perhaps chemotherapy 5 years ago caused you some lung damage. Well, that puts you in a different group. But in the years that I've taken care of cancer patients, I haven't actually had any of my patients had long-lasting lung damage. So I think that scenario is very unlikely. So in general, for a 5-year survivor, I don't think you're at an increased risk of getting COVID.
There's another question, Ellen, about chemo and antibody blood work.
I just saw that. So the antibody testing, so I can spend a moment talking about that. So the Infectious Disease Society of America, the IDSC, has an open website which you can look at, and they are trying to keep it very updated. It looks to me as if they're updating it every week. I'm sorry, almost every day. They currently have no recommendations on who should get antibody testing. And that's probably because it is too new and we don't know what to do with it or how reliable the results are. So I have many colleagues at different institutions, large institutions across the country. We were discussing what we are doing for our patients right now for the antibody testing. And we are not, there are no guidelines, and we have not, none of the big institutions are reliably testing their patients. Now, there might be some patients who are in a situation where they're hoping to know because they think they've been exposed and they want to know because it might affect their treatment in some way. But unless there was a specific situation, the recommendations right now are that across the board, you wouldn't necessarily test chemotherapy patients. In fact, the way it's being used right now at some of the big centers in our area is they're just testing their staff to see epidemiologically what their rate is. And is it higher than the study in New York, which suggested it was 15 to 20%? So nobody knows who to test. And the other thing, and maybe this is some of my cynicism about these tests, but the coronavirus testing to see if you have it is only about 70% accurate, which means there's 30% false negatives, perhaps more. So I wonder what the results will ultimately be on the antibodies. So the answer to that is I wouldn't recommend it. There's a question, if I finished chemotherapy 2 months ago, how much longer is my immune system compromised? So if someone has normal blood counts and they've been checked after chemo and their white count has come back up, we generally think that within a few months of chemotherapy, well, within a few weeks, you're through the period where you'd be most immunosuppressed. Within a few months, I would actually think that your immunity is close to normal. I'm talking about breast cancer specific chemotherapy. For patients who have lymphoma, leukemia, that's a very different story because they might be on drugs that can affect their immunity for months to over a year or might have had a transplant. But for the breast cancer patients, within a few months, I would expect that your immunity is pretty much normal.
I can address, or Lisa, if you want to address the question regarding reducing risk if there's a family member.
Sorry, I can't see the chat.
It said the question was, what lifestyle recommendations do you recommend to reduce chance of getting breast cancer if you have a sister with breast cancer?
Okay, so some of that does have to do with genetics. So that can kind of vary depending on if there's a genetic component, if you know that or not. And what we can certainly, we change screening recommendations if we know that you're at a higher risk. Sometimes that may mean adding in screening with MRIs. And again, these are kind of very specific situations. So without knowing the specific situation, it's hard to make a definite recommendation. But certainly for everyone, as far as just kind of doing things to keep your breast cancer risk low, are just, maintaining a healthy lifestyle. What we kind of say for most everything, maintaining what we consider like a heart healthy diet, getting regular exercise, avoiding smoking, keeping your alcohol intake to a minimum, all of those kinds of things that can work for everybody. And then obviously, there's really no way to truly prevent breast cancer, but certainly what we'd want to do is make sure that if you are at a higher risk, that it be caught as early as possible by doing the routine screenings, by seeing your physician. And now I know we talked about a lot of the routine screenings being on hold, but that month or 2 or even 3 is not going to put your risk through the roof. And certainly if you fall into other high-risk categories where we would be talking about doing prophylactic surgeries or chemo prevention, probably this wouldn't be the best time to be doing that during the pandemic, but certainly something where we would see you, we could evaluate you, we kind of get a better idea what your true risk is and what would be the best way to move forward. I don't know, Dr. Ronnen, if you have anything else to add to that from like the chemo prevention standpoint.
No, and I think what you said when you started off is very important, which is the subgroup that we are always trying to think about is the subgroup that have a family history making us suspicious, or an ethnicity history suspicious that there might be a deleterious gene in their family. Those patients might get different monitoring, but in terms of lifestyle recommendations, I entirely agree with Lisa, which is, there is data, and I talk to my patients about the data, that there is data that prevent recurrence for estrogen receptor positive breast cancers in terms of, maintaining a healthy body weight, exercise a few times a week. Exactly what you said, Lisa, I agree. And I think that overall, we think that that might reduce the risk of getting it in the first place.
Lisa, there was another question. My mother-in-law has been diagnosed and does not want surgery. Is there a way to go straight to radiation? No one to.
So I guess we can kind of tackle that one together.
Yeah.
There are certainly some situations, and I didn't go into a lot of detail with my slides, but there are certain situations right now where we could certainly delay surgery, or very specific situations where we could possibly omit surgery. As I mentioned, surgery in general for breast cancer, especially small tumors, is fairly low risk in kind of the scheme of things. So we can safely get most women through surgery okay, without having really any major complications or things that would require hospitalizations. I can't think of too many situations where we would just skip over surgery and go straight to radiation. There might be some situations for some small low-grade tumors and someone who has a lot of other medical issues that would keep them from being a good surgical candidate, where maybe if it's an estrogen receptor positive tumor, they could go on endocrine therapy for a period of time. But I don't know that there would be any role for just going straight to radiation, unless you can think of.
No, I completely agree. I mean, I think it's especially if for anyone, if their medical team is recommending surgery, they're really, surgery for breast cancer works so much better than radiation as a replacement for surgery. And I sort of mentioned that there are times where we use it, but it's sort of the non-ideal plan B to C, and really not a replacement. Certainly not something I think we should be thinking about because of the pandemic and because of anxiety about exposure. I think there's lots of other things we can do to still do the right treatment, which almost always is going to involve the surgery as being the initial portion of it. And I wouldn't use radiation as a replacement for most people.
And I've had a few patients who were older and didn't want to have surgery, although I did have their cardiologist clear all of them. And, but it's a personal preference. And all of them, over the years, I've been accumulating a steady small stream of them. All of them are doing fine on their endocrine therapy. I do not recommend this as a standard, but all of them were significantly older and often in their 90s, and they had other medical problems. And so we did do that. I haven't had someone who went from nothing to radiation, but I have had a few who went to endocrine therapy, and they're doing okay. They're fine. Their tumor hasn't changed. They get imaging to follow it up, and they look healthier than I do.
And
again, I think, sorry, go ahead, Lisa. I was going to say, I think these are all sort of individualized things that we or other teams may consider, but I really would not want these decisions to be made because of this pandemic. I think that avoiding the proper needed care in order to lessen your risk of exposure, I think there has to be this balance, and I certainly wouldn't look at any of these options because of this fear of going into a medical facility. All right, I think that seems like, and Christine asked us to make sure that we're also taking care of ourselves, and I agree. I think all of us, everybody feels stressed. Medical professionals and all, but thank you, Christine.
And thank you.
Thanks, Christine.
All right.
Take care, everyone.
Take care, everyone. Thank you.
Thank you for coming.